Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. I want to describe a version of a Tuesday that I think a lot of you will recognize. You're up at 6, you make lunches, sign the permission slip you forgot about last night, answer 2 emails before your feet hit the floor, remind someone to brush their teeth 3 times and get your kids to school. Then you drive to the office, the hospital, the courtroom, the client call, whatever your particular arena is, and you perform. You are excellent. You are the person everyone else brings their problems to. You make complex decisions under pressure. You manage teams, caseloads, patients, deals. You do it well. You have always done it well. And then you go home and you do the second shift, homework, dinner, the emotional triage of figuring out why your 10-year-old is upset about something that happened at lunch, the mental load of the calendar, the appointments, the follow-ups, the things only you seem to know are pending. And somewhere in there, you're also supposed to exercise, connect with your partner, sleep 7 to 8 hours a night, and take care of your own health. If you are in your late 30s or 40s, I want to ask you something. When did you last feel genuinely rested? Not just like you slept, but actually restored. When did you last feel like your mood was your own, not a hostage to your sleep quality and your calendar? When did you last feel like your body and your brain were working the way they used to? If you cannot remember, this episode is for you. Because what you have been calling burnout, what your doctor may have called burnout, what your therapist may have called burnout, what you have privately told yourself is just the price of this season of life, maybe something more specific, something measurable, something that has a name and a mechanism, and importantly, an intervention. I am Dr. Arti Thangudu. I'm an endocrinologist, a mother of 2 school-aged kids, and someone who has sat on both sides of this conversation. This is Endocrine Matters. I want to name a specific population because I think precision matters here. I am talking about women in their late 30s and 40s who are at the peak of their professional careers and in the thick of active motherhood. The physician who is building a practice and raising a 9-year-old. The attorney who made partner the same year her second child started school. The entrepreneur who launched a company and is also the room parent for the class holiday party. The finance executive who manages 9 figures of other people's money and also manages the pediatric appointment schedule for her household. These women are highly competent. They are high functioning. They are, by most external measures, doing incredibly well. And they are also quietly and often invisibly running on empty. They are experts at appearing fine. They were trained to appear fine, professionally, socially, as mothers. Appearing fine is practically a job requirement. Here's the thing that I find genuinely alarming about this group as an endocrinologist. They are the least likely to seek care for themselves, not because they do not know better, they often know exactly better, but because seeking care requires time they do not have, vulnerability they have learned to suppress, and the implicit admission that something is wrong with them specifically, rather than with the situation they are in. And when they do seek care, they are often told what I mentioned before. It is stress, it is a season of life, it will pass, come back if it gets worse. That answer is not wrong exactly. The stress is real, the season is real, but it is incomplete. Because for many of these women, there's a biological layer underneath the circumstantial one, and nobody is looking for it. Let me tell you what I'm actually looking for when a patient like this walks into my office, because it is not one thing. It is a collision of things that tend to arrive at the same time, in the same body, in the same decade of our life. And when they pile on top of each other, the sum is something that looks and feels a lot like what we call burnout. But it is not only that. The perimenopause layer. Perimenopause can begin as early as the mid-30s, though for most women it starts in the early to mid-40s. And here is a timing problem that I think about a lot. The years where perimenopause is most likely to begin are the same years when professional women are at or near the peak of their career demands and in the most logistically intensive years of active parenting. School-age kids, roughly 6 to 14, require a different kind of parental presence than infants or teenagers. They need you engaged, emotionally available, intellectually present. They have schedules, friendships, academic pressures, developmental questions that need a parent who is actually in the room. And the perimenopausal transition is, biologically, a time when the hormonal architecture that supports all of that, sleep, mood regulation, cognitive clarity, emotional resilience, is actively shifting. Estrogen and progesterone do not just govern the menstrual cycle. They're deeply involved in serotonin regulation, GABA activity, the calming neurotransmitter, and sleep architecture. When progesterone begins to drop, which often happens first, women start noticing changes in their sleep even before their periods become irregular. That 3 a.m. wakefulness, wide awake, mind racing, cannot get back to sleep, may not be anxiety. For many women, it is progesterone withdrawal, and no amount of journaling or mindfulness is going to fix that. The cortisol layer. Cortisol is your stress hormone. In acute situations, it is adaptive. It sharpens focus, mobilizes energy, prepares you to perform. The problem is that the professional mother's stress is not acute, it is chronic. It is the background hum that never fully resolves, the inbox that is never empty, the mental load that does not clock out, the baseline vigilance that comes from being responsible for the well-being of multiple humans simultaneously. Chronic cortisol elevation has measurable physiological consequences. It disrupts sleep architecture, it worsens insulin resistance, it suppresses immune function. Generally, your labs can look fine, but you feel like you're operating in slow motion. The thyroid layer. Thyroid disease is more common in women, peaks incidence in the perimenopause window, and shares symptom overlap with virtually everything else on this list. Fatigue, brain fog, weight changes, mood dysregulation, cold intolerance, hair thinning. These are hypothyroid symptoms, and they are also perimenopausal symptoms, and they are also what chronic sleep deprivation does to a body. The clinical picture blurs. Symptoms get attributed to the most obvious cause, which is usually stress or lifestyle, and underlying thyroid disease gets missed or undertreated for months or years. Hashimoto's thyroiditis, the most common cause of hypothyroidism, is an autoimmune condition. Autoimmune conditions in general are worsened by chronic stress, sleep deprivation, and nutritional insufficiency. So the same conditions that are making this woman's life harder are also at the biological level potentially worsening an underlying autoimmune process. The lifestyle is not separate from the physiology. They are the same story. Let's talk about the iron layer. This one is underdiagnosed and undertreated, and I want to spend some real time on it. Perimenopause is often accompanied by changes in the menstrual cycle, like sometimes heavier periods or more frequent periods or irregular bleeding patterns. Heavy or prolonged menstrual bleeding depletes iron. Iron deficiency does not have to reach the threshold of frank anemia to cause significant symptoms. Profound fatigue, reduced exercise capacity, brain fog, low mood, hair shedding, restless legs at night that are disrupting sleep. I have patients who have seen multiple providers and been told their blood count looks fine, and it did look fine because we were checking hemoglobin rather than ferritin. Ferritin is a storage form of iron. It drops before hemoglobin does. A woman can have a normal hemoglobin and a ferritin that is low and feel genuinely terrible. And every test will come back unremarkable unless someone specifically checks her ferritin. If you have never had your ferritin checked and you're experiencing the kind of fatigue I'm describing, please ask for it at your next appointment. It is a simple blood test, and if it is low, treatment is available and often can be effective. Next, the sleep layer. I have saved sleep for last in this list because I want to be clear that it is not a separate item. It is the thread that runs through every other one. Inadequate sleep, which I will define conservatively as fewer than 6 to 7 hours of quality sleep, worsens insulin resistance, elevates cortisol, suppresses immune function, reduces emotional regulation, and accelerates the very perimenopausal symptoms that are disrupting sleep in the first place. Sleep deprivation is not a badge of productivity. It is a physiological stressor with compounding consequences. And for the professional mother of school-age children, chronic, mild to moderate sleep deprivation is often just the baseline condition of her life. Here's the paradox I see in my practice constantly. The women who are the most competent, the most organized, the most skilled at managing complexity are often the ones who have been running on empty the longest before anyone catches it, including themselves. And I think I understand why. High-achieving women are experts at triage. They have spent their careers learning to prioritize, defer the non-urgent, to push through discomfort in service of the goal. Those skills are genuinely valuable. They are also, when applied to your own health, genuinely dangerous because your health keeps getting triaged to the bottom of the list. It is always not urgent enough. You are always functioning well enough. You can always do it next month. There's also an identity piece that I want to name directly because I think it operates beneath the surface for a lot of women in this group. If you have built your sense of self around being capable, around being the one who figures it out, who does not need help, who holds it together, then admitting that you are depleted feels like a threat to that identity. It can feel like a weakness Or like ingratitude because you have a good life, a career you worked hard for, children you love, and you are aware that other people have harder circumstances, so you do not say anything. You tell yourself to be grateful and push through. I want to offer a reframe. What you are experiencing is not a failure of gratitude or resilience. It is a physiological response to extraordinary demand occurring at a biologically vulnerable window. Your body is not broken. It is responding appropriately to everything being asked of it. The question is not why you cannot handle this better. The question is whether anyone has actually looked at what is happening inside your body, or whether everyone, including you, has just assumed it is stress and moved on. I will say something personal here because I think it belongs in this conversation. I am a physician who specializes in exactly these conditions. I know this physiology. I counsel women through it every single day. And I have still been the last person in the room to apply it to myself. I have attributed my own 3 a.m. wakefulness to the business of building something. I have told myself the fatigue was the price of the life I chose. I have more than once triaged my own health to next month. The knowing does not automatically protect you from the pattern, which tells me that the pattern runs deeper than information. It runs into how we are wired to think about ourselves and our needs. I'm not going to tell you to meditate more or set better boundaries. Those conversations have their place, and this is not that episode. What I want to give you is a concrete clinical checklist, the things I would look for if you walked into my exam room describing what I have described today. First, get a real thyroid workup. If you have symptoms consistent with Hashimoto's, like fatigue, family history of autoimmune disease, fluctuating symptoms, you can ask for a TSH, perhaps free T4. Free T3 assays have gotten a bit better recently, or antibodies like thyroid peroxidase and thyroglobulin antibodies. Not everybody with Hashimoto's thyroiditis does have positive antibodies, but this is something that's an easy screening test. It's just a basic blood test. Also, check your ferritin, not just your hemoglobin. Ask specifically. A CBC will not always catch iron deficiency without anemia. A low ferritin can cause significant symptoms and may be worth treating. This single test has changed the trajectory of care for many of my patients. Have the perimenopause conversation. If your physician does not bring it up, you bring it up. If you are in your late 30s or 40s and your periods are changing, your sleep is changing, your mood or cognition feels different, say the word perimenopause. Ask whether your symptoms fit that picture. Ask whether there's a role for evaluation or treatment. You should not have to wait until your symptoms are undeniable to have this conversation. Treat sleep as a clinical priority, not a lifestyle aspiration. If you're constantly getting fewer than 7 hours of sleep, or if your sleep is fragmented and non-restorative, that is a medical problem with metabolic and hormonal consequences. It is not a scheduling inconvenience. Ask your doctor about it. Consider CBTI, cognitive behavioral therapy for insomnia, which has strong evidence and no side effects. If the sleep disruption is hormonally driven, treating the hormonal cause is part of the solution. Add resistance training, even imperfectly. If I could prescribe one thing to every woman in this demographic, it would be resistance training 2 to 3 times a week. It improves insulin sensitivity, preserves muscle mass, supports bone density, improves sleep quality, and has well-documented effects on mood and cognitive function. You do not need an hour. You do not need a gym. You need progressive resistance and consistency. Something imperfect done regularly beats something perfect done never. Eat enough protein, especially if you are also restricting calories. Many women in this group are under-eating protein while simultaneously over-restricting calories in an effort to manage weight changes that are actually hormonally driven. Inadequate protein worsens muscle loss and slows metabolism further. Aim for at least 0.7 grams of protein per pound of weight daily, ideally more if you're strength training. It is not a number most women are hitting. The most capable women I know are also quietly among the most depleted. Not because they are doing anything wrong, because they're doing everything right, for everyone except themselves. What I want you to take away from this episode is not a to-do list, though I did give you one. What I want you to take away is permission. Permission to name what is happening in your body as something real and investigable, rather than just the cost of the life you chose. Because it is not the cost, it is a signal, and signals are meant to be read. Share this episode with the woman in your life who is holding the most and saying the least about how she feels. She will recognize herself, and that recognition, the moment when what you have been privately experiencing finally has a name and mechanism, and someone who takes it seriously, can be the beginning of something that actually changes. For deeper dives into perimenopause, thyroid health, and metabolic medicine, keep listening to Endocrine Matters. I am Dr. Arti Thangudu. This is Endocrine Matters. Take care of yourselves, and I mean that as a clinical instruction, not just a platitude.